Okay, the first case study we're going to look at is Melissa, 16 months old, and her mother has brought her to the clinic for her well child visit. She looks pale and has a hemoglobin of 7.8 grams per deciliter. Her mother has not volunteered any concerns, but when questioned specifically, she does indicate that Melissa has not been very active and has had a few colds this winter. Her mother acknowledges that she does not eat very well, but has always taken her bottle. She says, "Isn't milk the perfect food?" Melissa is carrying her bottle with her. Melissa is diagnosed with iron deficiency anemia, and an iron supplement has been prescribed. Okay, if you guys remember some of the causes of what would cause iron deficiency anemia, so kind of think about all the causes and then what would cause this for Melissa. I'm going to go with poor nutritional intake is what I'm going to go with. Your first question is, what information should the nurse give Melissa's mother about milk intake? What we need to make sure that the mom knows is that cow's milk tends to irritate the human intestine. Cow's milk tends to bind to iron in the intestine and carries it out in the stool. Around age 1, the recommended daily allowance is 16 ounces of milk per day. And just to kind of give you some guidelines about that, a single slice of cheese has 5 ounces of milk in it, and you can give her some kind of examples that she would understand as well. It says, explain why iron deficiency anemia is common in the toddler age group. Toddlers, they really do enjoy their milk. We call them milk babies. They like their bottle, so they fill up on milk and then they don't want to eat anything else. Preferences for iron-rich food, which we'll talk about here in the next question, some of them aren't the best or aren't the most probably appealing choices to a toddler. Let's see, your next one is, how can Melissa's mother encourage her daughter's intake of iron-rich foods? She can do, well, obviously dietary counseling, oral supplements, or drops would be recommended. And again, make sure that they're taking with a citrus juice. The acidity aids in absorption of oral supplementation. I know Melissa is at the age of 16 months, but if you are looking at somebody younger, make sure it's breast milk and formula for the first 12 months, no cow's milk. We talked about citrus juice, so basically vitamin C facilitates that absorption. And then some other dietary things that she could do is offer milk after solid foods with higher iron concentrations have been eaten. We find iron in red meat, organ meat, trying to see what else. I'm reading my notes over, hold on, sorry. And then of course, obviously iron fortified cereals. I know toddler cereal has a lot of iron in it for this reason, but if you look at most cereal that kids eat, adolescents eat, it is iron rich cereal. Okay, we talked about that. And then what we need to teach her about iron supplementation, we already talked about giving it with vitamin C to facilitate the absorption. One thing to be aware about with the drops is it does stain the teeth, so they should take it with a straw so it gets deposited into the back of the mouth.
Okay.
And make sure that Melissa's mother is aware what it does to the stool. It can turn it black and greenish in color. Iron is constipating, so we need to increase fluids for Melissa. And then also that the iron drops themselves have a foul aftertaste. We can do IM or IV if oral is not working, but hopefully she will be well taken care of with the oral drops, so we don't have to go that route. What is the most effective approach to use with a caregiver who seems concerned but is not always aware of the significance of changes? as may be the case with Melissa's mother. Again, it's really just educate, making sure you're asking good questions, open-ended questions, and again, with a non-judgmental attitude. And make sure that she understands your teaching and that you guys are modeling the behavior you want her to emulate once she goes home, and to make sure she's doing a return demonstration. And again, just to reiterate the iron-rich foods, we talked about meat, organ meats like liver, which again, I don't know any 16-month-old that's going to want to eat liver. Green leafy vegetables, and we talked about infant cereals, and then as well as other cereals. Some other things I have to say about iron deficiency anemia on the case study, well, just in general. Not sure if it was in the lecture. I have it on the case study, so I'm going to make sure that I go over it here. When you have somebody coming in with an H&H very low, Melissa's H&H is an extremely low at 7.8. Let me switch over to the other handout, the milk baby here, because this one we'll talk about a low hemoglobin here. I'll go over that after I read you my notes. So if the H&H is very low, the heart rate increases because thin blood is pumped a lot faster, because we're worried we need that fast blood flow to carry enough oxygen to the cells of the body. So the number one goal with iron deficiency anemia is to increase O2 supply to body tissues and promote adequate rest. And again, we would want them in a semi-Fowler's position. We may be giving them oxygen. We would assist with ADLs and provide periods of rest. So that's the first thing we're going to do. Second thing we're going to do, and again, we're doing these two things simultaneously, but if you think about your ABCs, we need to increase that oxygen supply first, and then we have to correct the underlying issue, and the underlying issue is the iron deficiency. So we need to increase the intake of iron-rich foods to meet minimum daily requirements, and also to replenish those iron stores, okay? The treatment almost always, even when we get to this milk baby case study that I put up here, the treatment is almost always iron over blood. Very rarely will we transfuse. We transfuse only with severe anemia, with severe signs and symptoms. Any cardiac dysfunction, any infection going on with it. They actually get better quicker with giving them iron. So really the treatment will depend on the cause. So figure out what's causing it. If it's a dietary issue, we talked about all the ways that we can help improve the dietary needs. And again, if it's anemia because of a trauma, something like that, where they've lost a lot of blood, we may replace the blood then. So if we look at the milk baby, it says a milk baby is a toddler, and they're usually a big chubby one. They're allowed to drink a lot of whole cow's milk, 32 to 40 or more ounces per day, to the exclusion of other foods. Cow's milk tends to irritate the human intestine. It binds iron in the intestinal system and carries it out in the stool. And it carries out in excessive amounts that leads us to the iron deficiency. So the milk literally sucks the iron out of the body. I talked about the slice of cheese already. The next paragraph talks about when the diagnosis is made, the blood count can be very low. The child's heart rate can be increased because then blood has to pump a lot faster. We talked about that. This doctor talks about they had a case not too long ago when the child had a hemoglobin of 5, and normal would have been around 10 or 11 for that patient. And again, his treatment was iron, not the transfusion. So again, iron deficiency anemia.